Re-evaluation of conventional abdominoperineal excision will be outlined in this section. The behavior of rectal cancers varies according to their location. For practical reasons, the rectum is divided into 3 parts. The first 6 centimeters from the anal verge is the lower rectum, and we will be mainly overviewing the management of lower rectal cancer in this section. The management of lower rectal cancer is almost always challenges the surgeon. Reviewing the Norwegian rectum cancer data, approximately 40% of all rectal cancers are located in this location, less than 5 cm to anal verge. Miles described abdominoperineal excision for rectal and distal sigmoid cancers early last century. Since then, the biological characteristics of this cancer are more clearly understood. The physiological relationship between the rectum and the sphincters has been determined, and modern surgical techniques have been developed. As a result of these, we are now able to restore bowel continuity and preserve fecal incontinence in many patients who undergo radical excision of the rectum for distal cancers. However, in some cases, achieving total cure precludes the use of sphincter-preserving surgery in low rectal cancer. In such cases, abdominoperineal excision is inevitable. At this point, I will ask Torbjørn to continue with the indication of abdominoperineal excision in low rectal cancers in detail. Torbjørn.
Yes, Ian. As you mentioned, Miles performed APE for all rectal cancers, but of course the indications for APE have changed with time. And today, the indications in the specialized centers, where we have highly specialized surgeons, are completely different. In most such centers, the APE rate is less than 10%, and includes only the very low or very advanced tumors. However, in reality, the rates of APE vary significantly in different institutions, between less than 10% up to 50%. In Sweden, for example, for low rectal cancer less than 6 centimeters from the anal verge, APE is performed in about 75% of the patients. There are several factors affecting the decision for EP, and these are mainly tumor-dependent variables and patient-dependent variables. Among the tumor-dependent variables, the level of the tumor is of course very important, and how low into the anal canal the tumor grows. The location of the tumor, anterior versus posterior, is also important, and maybe the most important factor is the depth of invasion. If the tumor invades or threatens the puborectal muscle or the pelvic floor or the external sphincter, then of course we have to make an APE. Also, if the tumor is more advanced, growing into the sacrum or coccyx or prostate, we have to make a more extensive operation and an APE. Some patients fail to respond to neoadjuvant therapy, and in such patients we may need to do an APE instead of a low anterior resection. There are also important patient-related variables such as age, sex, and sphincter function. In patients with anal incontinence, we should not make a low anastomosis because the function will be poor, and in such patients an AP may be better. Also, if the patient has comorbidity like systemic disease or psychological or neurological diseases, we may have to make a stoma and not an anastomosis. Now, Phil, I would like you to tell us about the oncological results after the conventional type of AP.
So we know from the results of standard abdominoperineal excision in the United Kingdom that we see a higher local recurrence and a poorer prognosis. And we've generated some data from Leeds, from the Yorkshire region, which is a 3 million population, and from the English population of 49 million. And they all show the same results, which is that the abdominoperineal excision has an 8 to 10% worse 5-year survival than an anterior resection. We've also shown, through work with the Dutch TME trial and in CR07, that the quality and planes of surgery are worse in the abdominoperineal excision. In the CR07 study, we saw an improvement in the planes of the anterior resections, but we saw no improvement in the planes of the abdominoperineal excision over the time of the trial. Our data isn't alone. There's data from the Norwegian rectal cancer study showing, again, a similar poorer survival of abdominoperineal excisions over anterior resections. Furthermore, here's another study published in the British Journal of Surgery, which again showed the higher local recurrence and the poorer survival of abdominoperineal excision. So low rectal cancer is still a major problem. It has a higher local recurrence that's double that of anterior resection, and it has a 10% poorer survival. What do we think the cause of this is? Well, we believe it's the type and quality of surgery, in that we see circumferential resection margin positivity in abdominoperineal excisions that are 2 to 3 times as high as anterior resections. And furthermore, the perforation rates in abdominoperineal excision are up to 4 times higher than anterior resection. There's more extensive data here, firstly in a lead series from 1986 to 1997, in the low rectal cancers below 6 centimetres in the Mercury trial, in the rectal cancers in the Classic trial, in the Dutch TME trial, in the Trent Pelican study, where we trained the Trent surgeons in mesorectal excision, in the MRC CR07 trial, and in the Norwegian audit. All of these show substantially higher circumferential resection margin involvement for abdominoperineal excisions than anterior resections. The actual frequencies depend upon how old the series is. The older the series, the higher the rates of circumferential resection margin positivity. In the lead series, we saw very high circumferential resection margin positivity rates in the abdominoperineal excisions, up to 36.5% over this time period of 1986 to 1997. And this led to a much higher local recurrence rate and a much poorer cancer-specific 5-year survival. These rates were much higher than we see today, but they're an example of the type of surgery that we saw at the time. Likewise, Iris Nagdegaal in the Dutch TME study and Arnie Wiebe in the Norwegian audit also show that the low rectal cancers, less than 5 centimetres, have much the highest rate of circumferential resection margin positivity. So in the Dutch study, 25.9%, and in the Norwegian audit, 10.6%. And this was much higher than that seen in cancers between 5 and 10 and 10 to 15 centimetres. In the Dutch TME study, Iris Nagdegaal showed that if you had a circumferential resection margin positive in an abdominoperineal excision, that you had a local recurrence rate of 30% and a 5-year survival of 38%. If you were margin negative, then your local recurrence rate was 9% and your 5-year survival was 72%, a very large difference. The perforation rate in abdominoperineal excisions versus anterior resections varies very substantially. In the Dutch TME trial, 13.7% to 2.5%, and big differences in the Norwegian audit and the Swedish audit. The rate of perforation of abdominoperineal excisions being 4 to 5 times that of anterior resection. In the Norwegian rectal cancer group, they were able to show that if you had a perforation, you had a very high local recurrence rate and a very poor survival as compared to no perforation. Very substantial differences in outcome if the cancer is perforated. Why do we see these problems with margin positivity and with perforation? Well, in the mid-rectum, the mesorectum is a substantial structure composed of fatty tissue and vessels, but as you descend through into the lower rectum, the mesorectum disappears and tapers off. The levators form the sidewall and gradually come closer to the muscularis propria, and then the mesorectum disappears, leaving puborectalis and the sphincter structures. So the anatomy changes dramatically from mid-rectum down to the sphincter structures, and as such the planes that the surgeons need to cut through need to alter to take account of this changing anatomy. Here we see some standard abdominoperineal excisions, and you can see that the mesorectal excision in most of them, apart from the one at the bottom right side, is fine. But on all of the specimens we see the coning in and the apple core effect in the low rectum where the sphincters are. And it is this effect that leads to problems with tumour clearance. And in the bottom left specimen you can see that there's a small perforation in the very narrow neck. We looked at the plane of surgery with Iris Nagtegaal in the Dutch TME study, abdominoperineal excisions. And what we found was that a third, so 36% of all the specimens, were either perforated or the resection margin, circumferential resection margin, was either in the submucosa, as shown in the lower two cross sections, or actually in the internal sphincter. That 2/3 of the specimens had the waist, and you can see that even they removed relatively little tissue. And within this study we could also see that there was high margin positivity, high perforations, and we're seeing margin positivity even in early T2 cancers, which had a margin positivity of 11.4%. So we can see from just studying the planes in abdominoperineal excision that there is a problem with this operation. Now I'd like to pass across to Torbjørn, who'll tell you about the surgical elements.
So, as we heard from Phil, there are several problems associated with the conventional type of APE. The synchronous combined APE is not a standardized operation, and therefore the results are variable and suboptimal. And we have also heard that the results are poorer than after anterior sections, mainly due to perforations and involved margins. As you can see here, when you do a traditional AP, you come down along the levator muscle close to the anus, and from below you go along the sphincters, and the specimen that you create will have a waist. Also in this animation you can see the similar thing. Coming down to the pelvic floor, going up to the same level, creates a waist, and if the tumor is there, there is a high risk of involved margin and perforation. Now I think it's time to change the concept of APE. In fact, there are 3 different APE procedures, and these procedures are related to defined anatomical structures in the pelvis. We have the intersphincteric AP, we have the extralevator AP, the issue anal AP, and later we will describe these procedures and their indications in details. Each of these procedures should be standardized, and the indications should be defined for each procedure. And these indications should be based on appropriate staging with MRI, ultrasonography, and of course clinical examination. First of all, the intersphincteric AP. As you can see here, we do as with a traditional TME surgery for low anterior section. We follow the plane down to the pelvic floor, and from below we follow the intersphincteric plane up into the pelvis. By doing this, we create a specimen that looks almost like a TME specimen for low anterior section, but with a small cuff of anal canal. The indication for intersphincteric AP is mainly patients unsuitable for bowel reconstruction. Patients with a history of incontinence, for example, or a high risk of anastomotic leak. In comorbid patients where it's crucial to prevent the leak because this may have a fatal outcome. And of course, some patients actually prefer to have a stoma instead of a bad function. In some patients with early cancer, like T1 and early T2 cancer, intersphincteric AP may also be an option instead of low anterior resection. The next type of AP is the extralevator AP. As you can see on this animation, in this case we come down to the levators, but from below we follow the external sphincter, the levator, and we meet at the top of the levator. This creates a more cylindrical specimen without the typical waist of the traditional AP. In this animation, you can see the similar procedure going down to the top of the levators, coming up along the levators, and in this way we have a good margin to the tumor, and the risk of involved margins are much less. The indications for the extralevator AP are tumors that are low, extending less than 1 centimeter from the dentate line, and tumors threatening the circumferential resection margin, such as the puborectal sling, the levator, and the external sphincter. In these cases, we have to do an extralevator AP. The third type of AP is the ischoanal AP. In this, you follow the mesorectum, but you stop, as with extralevator AP, at the top of the levators. But in these patients with often advanced tumors, we have to take the fat in the ischoanal fossa, and therefore we follow the obturator muscles and we meet at the level of the levators. The specimen will have large volume at the bottom, including all the ischoanal fat. The indications for this third type of AP are, of course, the locally advanced cancers infiltrating or growing through the levator muscles into the ischoanal fat, and also the large tumors growing in the perianal skin, such as large anal cancers. In perforated cancers with an abscess or fistula in the ischoanal fossa, we also have to perform this operation. This is a typical case of a very advanced mucinous cancer growing through the levators into the ischoanal fossa. And as you can see here, this tumor is very advanced, and we have to remove not only the ischoanal fat, but also a piece of a gluteus maximus muscle to achieve a radical operation. So in order to improve the results after AP, we actually introduce the extended abdominoperineal resection in 2007, where we described our results. And there we could report reduced rates of perforations, reduced rates of involved margins, and also improved oncological results. The way that APE has been done at our institution is by the posterior perineal approach. In this approach, the patient is in the prone jackknife position. One surgeon can stand between the legs and have an assistant on each side. In this way, we have a very good exposure of the surgical field. If necessary, we can resect the sacrum. We have used gluteus maximus flap for a reconstruction of the pelvic floor, but there are, of course, also other options. With the extralevator AP, we avoid the waste of the specimen, we reduce CRM positivity and perforation rates, and thereby we improve the local recurrence rate and the survival. And maybe one of the most important features of doing the AP in the prone position is that it can be easily learned to our younger surgeons. We have published our results in 2007, but there have also been other institutions publishing their results from the extralevator AP. From Paris, Daney and colleagues in 2003 already published a very low local recurrence rate after AP with a very good survival. And as you can see, their specimens are also cylindrical without the waist. Similarly, from Poland, there has been a publication showing very low perforation rate, low circumferential resection margin involvement, and a very impressive low local recurrence rate and a good survival. Again, as you can see, this specimen from Dr. Bevenek shows no waist but has a very good wrapping around the tumor of levator muscle. Now, Phil, I would like you to show us the different types of APEs on the pathological specimen.
There are 4 types of operative specimen that you'll see with an abdominoperineal excision. The first is the standard type of abdominoperineal excision where the surgeon follows the mesorectal fascia down to the bottom of the mesorectum and then going through puborectalis will stop the abdominal approach and will then come from below to join up the operative margins. And this is shown in the picture at the side, and this shows the waist on a specimen which is a very good total mesorectal excision but has this waist which reduces the amount of tissue potentially around the tumour. The second major type is that of the extralevator, where the surgeon follows the mesorectal fascia down, but when he reaches the top of the levators, he stops, and then you can either turn the patient into the prone position, or you can go down to the perineum in the supine position, and then you will start dissecting up on the edge of the sphincters and join up with the abdominal approach by cutting through the levators wide. If you have a large, low tumour, then you may want to extend the operation, and what you can do in this situation is to actually go wider in the ischial-anal fat to create a bulge on one side of the specimen where the tumour is extending. The other type of operation is a total mesorectal excision with an intersphincteric removal of part or all of the sphincters. Here we have two standard abdominoperineal excisions on the left, one fresh and one fixed, both of which show the waist, but also in the upper one a poor anterior and posterior mesorectal excision. On the right hand side you have two of Torbern-Holm's abdominoperineal excisions, one fresh and one fixed, which show the completely different shape. You have a cylindrical shape, you have the protrusion of the coccyx, and the levators are attached to the lowest part of the mesorectum, providing those extra millimetres that you need. In the lower one of these, you have a slightly wider ischial-anal removal of fat. Now, on the left-hand side of this picture, you have an excellent abdominoperineal excision of the extralevator type, as you've seen before. But on the right-hand side, you see what happens if the surgical dissection from the abdominal part of the operation is extended too low. What happens is the levators are taken off and separated from the sphincters, and in this situation you've recreated the waist, and you need to avoid doing this because it negates the effectiveness of the extralevator operation. And in the early stages this is a common situation that we see. Surgeons will go down too far and lead to the recreation of the waist. We've looked at the benefits of this operation, getting together a group of surgeons from many countries, and here are some of the specimens that they produced. A is a standard operation produced in Leeds showing the waist. B is an extralevator operation performed by Paul Finan in Leeds, having been taught by Torbern-Holm. C is an extralevator from Garcia Granero in Valencia, and then D is a further extralevator operation from Exeter. D is an extralevator from Basingstoke from Brendan Moran, and E is an extralevator from Hull by John Monson. So what we did was to take the standard operations in Leeds and compare them to the new extralevator operations as performed by these other surgeons. In this multi-centre study, where we got together a group of European surgeons who had either been trained by Torbern-Holm or had trained themselves in this operation, we looked at the positive margins in both the standard abdominoperineal excisions from Leeds and extralevator operations undertaken by the European Extralevator Abdominoperineal Excision Study Group. And what it showed was that there was a major reduction in the frequency of margin positivity from the standard to the extralevator abdominoperineal excision, and also a major reduction in intraoperative perforations. And this was in a large number of cases, 176 extralevator APEs and 124 standard abdominoperineal excisions. We also undertook morphometric studies by Dr. West in our department, and what he was able to show was that in all the slices starting at the anal margin, moving up towards the middle of the mesorectum, what we could see was that there was an increased amount of tissue removed in the extralevator abdominoperineal over the standard abdominoperineal excision, and this extra tissue giving us more protection for the margin and reducing the perforation rate. What was also interesting was that we saw an increase in tissue in all 4 quadrants. So not only in the lateral and posterior areas where we would expect to see more tissue, but also in the anterior plane, which is a critical plane for avoiding perforation and margin positivity. And this is probably because of the better visibility of the operation as it is now performed. Thanks to the efforts of Torbjörn Holm and other surgeons, we now have a number of training programs which have been undertaken across Europe. So in the Trent region, in Denmark, the regions have been trained. In Scotland and now in England, we've started to train surgeons in this new technique. And the 4 pictures that you can see are examples of extralevator abdominoperineal excisions performed in Denmark just after the training, showing that this technique can be learnt.
So before we end this presentation, let me take the opportunity to summarize on AP in low rectal cancer. It's very important to assess both the patient and the tumor, the patient's function, comorbidity, and patient's preference. Of course, the tumor is important. In very low tumors or threatened CRM, we have to perform an APE. Once we have decided that APE is the correct choice, then what type of APE should we do? We can choose between intersphincteric, extralevator, or ischianal APE. The extent of the procedure must be planned preoperatively, and this plan must be based on a proper staging with MRI and a clinical examination of the patient. Once we have decided on the type of AP that we should perform, we should stick to that, and we should avoid changing approach during the surgical procedure.